Sorry about that. So unilateral tinnitus with or without hearing loss can have similar diagnostic implications. So when we look at the etiology of asymmetrical hearing loss, it can either come as an isolated complaint from a patient, or it can be a new symptom in a patient with pre-existing hearing loss. So generally in the population, a difference between the two ears is something that is possible to be found. And the prevalence of interaural thresholds between the two ears in the general population of more than 15% is acceptable, and the prevalence has been found to be around 1%. When we talk about vestibular schwannoma, we also know that it is, though it is a common presentation of retrocochlear hearing loss, it is a very rare finding, and it has been shown to have a prevalence of 0.5 to 2% per 0.5 to 2 per 100,000 in the population, and approximately 1% in cadaveric studies. So the etiology of loss guides the most appropriate treatment. On this image, we can see the possibilities of this image shows the auditory pathway, and asymmetrical hearing loss could present if there's a problem between the cochlear nerve all the way going to the level of the pons. Of note is that any other hearing loss that is caused by lesions that occur above the level of the pons, that is after the decussation of neural fibers, is highly likely to be bilateral, especially from patients who present with auditory cortex strokes. An entity that is commonly correlated with asymmetrical hearing loss is single-sided deafness. So this can be either profound or unilateral sensorineural hearing loss on one ear. Audiologically, it is defined as unaidable, severe to profound hearing thresholds with poor word recognition scores. So the prevalence of acquired unilateral hearing loss is around 12 to 27 per 1 million persons annually from multiple studies done. Another entity that is commonly associated with asymmetrical hearing loss is sudden sensorineural hearing loss, which is defined as a decrease in hearing of 30 decibels, affecting at least 3 consecutive frequencies, and one that has occurred over a period of 72 hours. It can either be reversible or irreversible. So what is the importance of symmetrical hearing? In children, bilateral hearing is important for their normal development of speech and language, which translates also to their cognitive development. In everyone, bilateral hearing is important for spatial perception and orientation of our heads or our bodies in space. It is also important for sound localization through the mechanism known as binaural summation, which is the ability of the ear to know the loudness and the distance between different sounds. Then there's also the ability to understand speech in noise or binaural squelch. So patients who do not have bilateral hearing have a difficulty appreciating sound or appreciating conversations in a noisy environment, what we would call a cocktail party effect. So patients with unilateral or asymmetrical hearing loss have proven or have shown to have significant disability and handicap. And this disability has been shown to almost match that of individuals with bilateral hearing loss. And most of this is attributed to the deficit in the spatial perception. So when you come across a patient who has asymmetrical or who has complaints in only one ear, you want to look at this patient systematically. Start with a good history physical exam, then go to audiometrical studies, then you can do some imaging studies and laboratory tests. And the main importance is to find out what could be the cause of the hearing loss. Is it cochlear, or is it a cochlear-related problem? Is it retrocochlear? And then treat the patient appropriately. So when you're looking at the history, the most common things you want to look at is you want to ask about the hearing loss. So you want to differentiate sudden versus progressive hearing loss. If the patient presents to you with sudden hearing loss, that is what we call an otological emergency. So you want to treat that patient as soon as possible, start them on steroids, because there is a chance to reverse the hearing loss within 72 hours. You want to rule out other symptoms such as otalgia, presence of discharge. Sensorineural hearing loss can occur in patients who also have chronic hearing loss. And these ones are the ones who might present with acute symptoms of otalgia, and some of them would present with also otorrhea as a symptom of chronic illness. Tinnitus is a very important symptom in patients who present with unilateral hearing loss. As you can see that a patient with unilateral tinnitus can be treated, or the approach to the patient is similar to the approach in a patient who presents with asymmetrical hearing loss, whether or not it is reported. So tinnitus is very important. It has to be a non-pulsatile tinnitus. Family history of hearing loss. Patients who have genetic causes of genetic sensorineural hearing loss tend to have a degree of asymmetry. Also noise exposure and other significant histories. You also want to rule out any vestibular symptoms in the patient. As we know, vestibular acoustic neuroma, most of the patients could present with vestibular symptoms. And also when you have patients who have inner ear disease, they also could have vestibular symptoms. In the additional history, you want to rule out history of trauma. Trauma would give you an asymmetrical or unilateral hearing loss. History of any previous otologic or intracranial surgery, especially around the area of the cerebral pontine angle or the temporal lobe. Patient with history of comorbidities. The most important comorbidities are things such as diabetes, vasculitis, hypertension, and any patient who could present with vascular disease. These are patients who could easily have ischemic or hemorrhagic vascular events that could make them present with unilateral or asymmetrical hearing loss, some of them with even vestibular symptoms. The history of occupation and the effect of the hearing loss on the quality of life, very important in deciding your management approach, especially for rehabilitation. So after taking a good history, you want to do a physical examination of the patient, and this has to be systematic. Once you have looked at the general condition of the patient and you want to do otoscopy, make sure that the patient has, patients with sensorineural hearing loss tend to have no, or for you to say a patient has asymmetrical hearing loss, you want to rule out any external ear or middle ear pathology. So you want to do otoscopy, which could be accompanied with pneumatic otoscopy to rule out any fistulas. Tuning fork tests are very important, especially when you want to correlate your audiogram findings. Cranial nerve exam is very important. This would help you localize if the patient has any central lesions, gait, and other vestibular exams such as nystagmus, Dix-Hallpike, head thrust, head shake. Now, the choice of tests here would be determined by the symptoms that the patients present with and the list of the differential diagnosis that you want to go through or from how the patient presents. When it comes to audiometric tests, mainly the first thing is you want to first rule out any middle ear or external ear pathologies. And you'll find that sometimes asymmetrical hearing loss can present as an incidental finding when a patient is undergoing audiologic screening. It is important to note that you can find patients with asymmetry while they have other pre-existing causes of sensorineural hearing loss. This is very common in patients with things such as other symmetrical causes of hearing loss, such as presbycusis and noise-induced hearing loss, which have been shown to to have a degree of asymmetry, especially due to genetic and environmental factors. So we have several audiometric screening protocols that exist and that can be used both in low resource settings and in high resource settings. And we also have several tests that should be used either in isolation or in combination. So for better sensitivity, it is better to combine results from biohistory physical exams and results from more than one audiometric tests. So when a patient has asymmetrical hearing loss, or when a patient has unilateral complaints, that is unilateral tinnitus or unilateral hearing loss, and you have ruled out any middle ear or external ear pathology, audiometry is done, one, to confirm that there is no middle ear pathology, no external ear pathology. And secondly, you also want to do audiometry to distinguish whether the lesion is within the cochlea or within retrocochlea, that is whether it is sensory or neural. Most of the times when you're suspecting vestibular schwannoma, because this is the main thing that you want to rule out in these patients, then vestibular schwannoma is a retrocochlear pathology, and so you would classify it in the retrocochlear category. So you can do several tests, including pure tone, finding the pure tone average, speech discrimination scores, short increment sensitivity index. This is a form of audiometry where instead of going up by 5 decibels when you're presenting the pure tones, you decrease the intensity to around 1 to 2 decibels, acoustic reflex test or acoustic reflex decay test. As I mentioned, each tool has its own limitations, and so it is more beneficial to combine the results and to have your history and physical examination in the background. So what do we look for in a pure tone audiogram? We define asymmetry in a pure tone audiogram as a difference in the intensity and in the configuration of the audiogram. That is the intensity being the average, the pure tone average. So when you use the pure tone threshold protocols, they have been shown to be sensitive by around 81 to 100%. And we defined asymmetrical hearing loss as a difference of more than 15 decibels between the two ears. And in this case, because we are talking about sensorineural hearing loss, you look at the bone conduction thresholds. So in this audiogram on the side, you can see that the bone conduction threshold on the right and the left, the right ear has a decrease, and the difference is more than 15 decibels. So that is a confirmed asymmetrical hearing loss. In terms of specificity, it has been shown to have a specificity of around 25 to 93%. This one varies in the different protocols. What I am talking about, or what I am defining right now, is the Nashville protocol, which has globally, from different meta-analyses and systematic reviews, has been shown to be the most sensitive audiometric protocol, where they take a difference of 15 decibel in 0.5 to 4 kilohertz frequencies. They also apply the rule of 3000 sensitivity, a difference of 15 decibel at 3000 kilohertz, which is not an octave frequency, so it is not commonly tested. However, it has been shown to be the most sensitive and has a sensitivity of 100% in picking up vestibular schwannomas. When you go now to the next thing, which is the configuration of the audiogram or the shape of your audiogram, it is not as sensitive as the threshold difference, and it has been shown to have a sensitivity of 38%. Now, of note is that a sloping high frequency loss is more sensitive compared to any other configuration of hearing loss when it comes to distinguishing patients with vestibular or schwannoma or retrocochlear lesions. Any low frequency hearing loss And any mountain shape kind of configuration have a sensitivity of 0. So they are not sensitive at all. And so you can rule out any patient who presents with such a configuration when you're deciding who to send for imaging. Again, if you look here, you can see this, the configuration of this audiogram. We have sparing of the low frequencies and diminishing of the high frequency. So this is a sloping kind of audiogram. When we're looking at the speech discrimination scores, which are also known as word recognition scores, so this is a suprathreshold test that is used to indicate how well a patient can perceive speech if the presentation level is increased. So how they do it is that they present the test to patients in order to distinguish between how well a patient can benefit from amplification, and also to distinguish between cochlear and retrocochlear pathologies. So usually the sound is presented at a higher threshold, and the patient is given a phonetically balanced word to present, and they are given a score. So in conductive hearing loss, due to the preservation of the cochlea, you find that the patient is able to score up to 100% with an increase in the threshold of the sounds as the sounds are being presented. In sensorineural hearing loss, then you find that a patient is also able to score, to have a high score. However, most of them, depending on the severity of the hearing loss, do not tend to get to 100%. Now, in retrocochlear loss, patients present with what we call a rollover phenomenon. So the rollover is when the speech recognition improves up to a certain point, and then it deteriorates in spite the increase in the threshold of presentation of the sounds. And from this, you want to calculate the degree of rollover, or where you take the maximum score, you subtract the minimum score, and you divide by the maximum score. If it is less than 0.5, then that is indicative of a rollover phenomenon. Of note is that rollover phenomenon is not tested, or speech discrimination tests are not conducted in patients who have either single-sided deafness or they have a severe to profound hearing loss on one side. Now, on this audiogram, you can see that this is a patient with a subtle asymmetry between the two ears. But when you look at their speech discrimination scores down here, you can see that for the right ear, they're able to go all the way to 100% from the initial 60%. So they started at 60%, and as the threshold went increasing, they went to 100%. And their articulation curve is going up. However, in the opposite ear, in spite of the fact that she has a bilateral pattern of hearing loss, you notice that as the sounds are being increased at 90 decibels, at 30 decibels, sorry, at 60 decibels, the patient scored 50%. But at 90 decibels, you would expect the patient to score better, but they score worse in the sense that they score 30%. And so their articulation curve is going down. So they are unable to appreciate sound with increasing thresholds. And that is a patient who has a characteristic rollover phenomenon. Now that is indicative of a retrocochlear lesion, and that is a patient you would want to send for an MRI. So when you're doing the acoustic reflex, the other test that you can do is the acoustic reflex test. This is done in patients after doing the tympanometry or during tympanometry. And the acoustic reflex threshold test is a test that is used to test the contraction of the stapedius muscle as a protective mechanism when presented with a high sound level. So it is a supra-threshold test. So it is used to detect the lowest level at which the acoustic reflex can be elicited. And it gives us information about the middle ear status, the cochlea, and the retrocochlear lesion. So when it is presented as both contralateral and ipsilateral. The ipsilateral pathway tells us about the middle ear status of that side of the test side, while the contralateral pathway tells us about the contralateral state of the other side of that is not being tested. So a normal reflex is elicited at sounds of around 70 to 100 decibels. When a patient has a conductive hearing loss, it can either be elevated if the loss is mild, or it can be totally absent. And most of the times it is absent due to the dysfunction in the middle ear. When a patient has a cochlear loss, if the cochlear loss is mild, then the reflex can be normal. However, if the cochlear loss is not mild, then most patients with cochlear loss, due to the recruitment phenomenon, have a reduced stapedial reflex threshold. So it is going to appear at lower levels, maybe at around 60 decibels or less. And this is due to the recruitment phenomenon that is present in patients with cochlear loss. When you have a retrocochlear loss, then it is either absent or elevated. And this is due to the fact that you would need a higher sound due to the high frequency hearing loss that these patients usually present with. So while doing the acoustic, this is an image that shows the acoustic reflex pathway. You can look at it at your own time. When you're doing the acoustic reflex and you're suspecting a retrocochlear loss, you can also do the acoustic reflex decay. And this is where, when you present the tone during the acoustic reflex, you want to keep presenting or to sustain the tone presentation for a period of around 10 seconds. Now, when you do that, then what the audiologist does is that they measure the sustainability of the acoustic reflex. Remember, this is a protective mechanism. And if you keep presenting the tone at a very high sound level, what is expected to happen is that the muscle is expected to keep contracting as a response, or the middle ear compliance is supposed to keep to be sustained. And so what we check for, we said that we examine the contralateral pathway to be able to diagnose retrocochlear lesions. And so if you have a positive reflex decay on the contralateral side, that is indicative of a retrocochlear lesion. So this is a normal or a negative stapedial reflex decay, where the sound was presented continuously for 10 seconds. And you can see that the deflection indicates the contraction, and the contraction of the muscle was sustained. In a patient, this is also another negative reflex decay. However, this one did not last up to the 10 seconds. It went decreasing. It is also a normal response. In retrocochlear pathway or in retrocochlear lesions, you find that the reflex is not sustained within the first 5 seconds. And this is what we call a positive reflex decay. So the reflex is present, but within the first 5 seconds of presenting the reflex, you find that the reflex decays and goes back to normal, and the contraction goes. And this is pathognomic of a retrocochlear lesion. Is a patient who can be sent for an MRI to rule out a retrocochlear lesion. The other test you can do is brainstem evoked responses, or the ABR. This is a test that is used to measure neural activity of the auditory nerve and the auditory brainstem response to acoustic stimuli. So usually is considered a very effective tool in the evaluation of cochlear and retrocochlear lesions. It's also very good as a threshold determination test. So it can also help you localize the level of the lesion if you're suspecting retrocochlear pathology, in the sense that the different waves of an ABR usually represent different parts of the acoustic pathway. So you see that the first wave represents the proximal, the first and second wave represent the proximal and the distal cochlear portions of the cochlear nerve. The third wave represents the cochlear nuclei at the level of the medulla. The fourth wave represents the nucleus of the lateral lemniscus at the level of the pons, and the fifth wave represents the level of the midbrain. And so you would be able, if what you want to look for is the shape of the waves, the consistency of the waves, and the interaural peak latencies. So there is a protocol when you're using ABR as a screening tool to diagnose vestibular schwannoma or to diagnose retrocochlear lesions. And the protocol is that you want to confirm that the patient has absence of evoked responses. So you can have a patient with a flat ABR. This is a patient who probably has a very large acoustic schwannoma with no hearing at all. You can have desynchronization of waves other than the first to the third. So you can have waves that are not consistent and they are not reproducible. You also look at the interpeak latencies. If there's usually the normal interpeak latency, that is the difference between the two peaks of the ABR should be 2 milliseconds. And if you have a difference of more than 2 milliseconds between two waves, then there is a delay in the conduction, in the nerve conduction, and you suspect that there's a problem or a lesion along the nerves or along the auditory pathway. You also, the difference between wave 1 and 5, if it is more than 4.4 milliseconds, again, is indicative of a problem in the conduction along the auditory pathway. And these 5 things can help you determine if a patient has a retrocochlear lesion and the level of the retrocochlear lesion, depending on where the morphological differences come about. It is a valuable tool and it has been shown to be cost-effective for screening. It has a sensitivity of 93% and a specificity of 82%. However, it has been shown that it is not very useful in patients who have small tumors because they tend to have normal ABRs, especially if they have not started by, experiencing any form of hearing loss or if they have a mild hearing loss. However, it has been recommended to be applicable and of use in low resource settings where patients do not have MRIs. Other tests that can be done to rule out vestibular schwannoma are either the caloric test or the hyperventilation tests. These are vestibular tests. The caloric test is a test where you irrigate the ear canals with either cold or warm water or air, and it is a test of vestibular hypofunction. So in this, it is not a very sensitive test and it is not really encouraged, as it has been shown to have a sensitivity of only 43% in picking patients with vestibular schwannomas. The hyperventilation test, however, has been found to be one of the most useful bedside tests for vestibular schwannoma, with sensitivities that go to as high up as 65%. So what you want to look for in this hyperventilation test is the presence of hyperventilation-induced nystagmus. It is a very simple test where if you have you can have your Frenzel glasses and you ask the patient to hyperventilate for a period of around 20 seconds. So you ask the patient to breathe fast, and during this, and then after 20 seconds, you ask the patient to stop and you look for nystagmus in any nystagmus, that is hyperventilation-induced nystagmus. In patients with the vestibular schwannomas or patients with retrocochlear lesions, they can have either excitatory lesions. This is where you have lesions in which the first phase is pointing, of the nystagmus is pointing towards the affected side. And this is a sign of demyelination, either patients with very, very large tumors or patients who have demyelinating lesions such as multiple sclerosis or any other demyelination brain pathologies. It can also present as a paretic kind of lesion where you have the first phase pointing towards the healthy side. this is a sign of vestibular hypofunction, and this could be especially in patients who have compression of the nerve on that side. Compression of nerve with gross vestibular hypofunction. Of note is that hyperventilation test can also be used in patients with vestibular schwannoma who have undergone stereotactic radiation to confirm if the radiation effect has caused a demyelination of the tumor. And it has been used, and so it is of use for that particular purpose when you want to follow up the patients or you want to confirm the effect of the radiotherapy. So imaging is the next step in your evaluation. So if you find a patient, you still suspect after going through the audiometrical test and you suspect the patient has a retrocochlear lesion or has a vestibular schwannoma, then the next step is to take them for imaging. And the gold standard tool of investigation in asymmetrical hearing loss is MRI. 20% of ENT requests in patients who present with audiovestibular lesions or audiovestibular symptoms usually are appropriate for MRI. However, we know that MRI is an expensive test. It is not readily available, and sometimes you tend to have very long booking times. So the best protocol would be a T1 and T2 images with a gadolinium enhancement. However, if you do not have gadolinium, then you can use T2 non-contrast scans. Studies done have shown that T2 non-contrast scans can be useful even as a screening tool and they have a sensitivity of up to 100%. This is cheaper than doing T1 and T2. It saves time and it also saves the resources. It saves the costs due to the cost of the contrast too. T2 lesions also can be done for follow-up of patients once you have diagnosed to check for interval changes between the tumor as a follow-up. You don't have to repeat the whole test protocol after you have confirmed the patient has a vestibular schwannoma. So you can also do a brain CT scan. And this is mainly in patients who have gross signs of space occupying lesions, or patients who have cranial nerve fallouts, or patients who have any localizing lesions. And this is to rule out any overt intracranial pathology which could be needing immediate neurosurgical interventions. CT scans are thus useful in that they can be used as a screening test if patient presents with worse or bad symptoms. So this is an example of a T2 MRI image. You can see the arrow on the left side here. It shows a small intracanalicular vestibular schwannoma. It is usually hypointense on T2. And this is a CT scan in a patient who has a large erosive CP angle lesion. So you can just use a CT scan to rule out an intracranial pathology if you're suspecting the patient, especially the patient has neurological or space occupying lesion signs. So CP angle lesions are different. It can be a vestibular schwannoma, it could be a meningioma, it could be a epidermoid cyst, and all of them present differently on imaging. That is for MRI and for CT scan. So you can go through this table. It shows the appearance and the contrast uptake of the different CP angle lesions. Any other findings that you can find in patients who present with audiovestibular symptoms could be arachnoid and dermoid cysts. The patient could be having a lipoma of the CP angle, lymphomas, gliomas, cholesterol granulomas, vascular loops or malformations, metastases from various lesions, most commonly prostate, breasts, and lung cancers, or they could also be having skull-based chordomas. So you do not just suspect a vestibular schwannoma in a patient who presents with asymmetrical hearing loss, especially if they have audiovestibular symptoms, other concurrent vestibular symptoms, sorry. So some of the patients that you must scan are patients who present with neurofibromatosis type 2. We know that these are patients who tend to have a high risk of having bilateral vestibular schwannomas. So if you have a patient who has features on neurofibromatosis, you want to really make sure you scan these patients. They could also be having other meningiomas and other neurological lesions. So it's important for you to scan them. Any patient who presents with a true subjective unilateral tinnitus or asymmetrical hearing loss, you want to scan them to rule out a vestibular schwannoma. Any patient with a rollover on word recognition scores or poor word recognition scores compared to the level of hearing loss, to rule out any retrocochlear lesion. Patient who have absent acoustic reflexes, patient who has and vestibular symptoms are also patients you want to scan, and patients who have progressively asymmetrical declining hearing with longitudinal audiometric follow-up. So this is a patient you see for the first time, and when you repeat their audiogram in 6 months, they have quite a significant decline in their hearing. You want to scan this patient to rule out an intracranial pathology. Laboratory investigations are another entity when you want to investigate these patients. And these are usually investigations that come to your mind when you have ruled out when you have ruled out a retrocochlear pathology. So there are other hematological or there are other causes of asymmetrical hearing loss that are not necessarily intracranial lesions or vestibular schwannoma. So here you want to do hematological tests, HIV tests. It has been shown that HIV, either from the medication or from any the viral infections or parasitic infections, some of these patients could present with asymmetrical hearing loss. Patients with syphilis. Syphilis is one of the commonest causes of treatable asymmetrical or treatable unilateral hearing loss. So you want to do tests to rule that out. Autoimmune mediated hearing loss can also present with a degree of asymmetry. So you want to do the ANA, ANCA, and the sarcoid tests in these patients. And you can also do CSF studies, especially in patients who have neurodegenerative diseases. The most common is multiple sclerosis. It can commonly present with hearing loss and vestibular symptoms as the only symptoms. So when you have a patient who you've ruled out everything, they are of middle-aged, you can think of ruling out that as a neurodegenerative disease. So I will end with a case presentation of 2 patients who presented differently and ended up with different pathologies. Patient A is a 70-year-old female who presented with a left progressive hearing loss over 1.5 months. The hearing loss was sudden, was sudden. However, it declined gradually after it occurred. Had associated tinnitus that was ringing in character, and patient had frequent headaches. Now, they did not have any vestibular symptoms, and of note is that the patient was a well-controlled diabetic hypertensive patient, was also a patient with hyperthyroidism on medication, well-controlled, and arthritis. The second patient was a 32-year-old female who presented with a right-sided hearing loss that presented over 10 months. It was a gradual onset with a sensation of oral fullness. She also had ringing tinnitus on the same side, and the symptoms were not fluctuating. So she also had temporal region headaches that were dull, that could come for a period, and had multiple episodes of dizziness that lasted seconds to minutes with associated nausea. She did not have any otalgia, otorrhea, or photophobia, phonophobia, or any presenting auras. Both patients did not have any history of family history of hearing loss, no history of noise exposure in both. And the second patient, being young, did not have any comorbidity. So when it came to examining, our first patient was elderly in good condition, but was using a walking aid due to her arthritis. The second patient was young, very good condition, but of note had an elevated blood pressure of 160/80. The head and neck exams in both patients were normal. Both had normal otoscopy, and both had tuning forks with the C2 that were agreeable with the findings. So the elderly patient had bilateral cataracts that were sorted in the course of her treatment. The young patient had an absent corneal reflex and what was seemed to be a decreased sensation on the left side of the face. The elderly patient, due to arthritis, had an antalgic gait, and but the young patient had a normal gait but had vertical nystagmus. All the other tests were negative, and we did not do the head shake or head thrust tests. So in our list of differentials, we thought that the elderly patient is a patient who had sudden sensorineural hearing loss and pre-existing presbycusis. We also, high on our list was an ischemic or vascular event, a CP angle lesion, or probability of vestibular migraine. For the second lesion, due to the localizing signs, we thought that the patient could be having a CP angle lesion, and part of our differential was possibility of vestibular migraines or Meniere's syndrome, or a demyelinating or autoimmune disorder. So these two audiograms are the audiograms of the two patients. So the first patient, who was the elderly patient, had a mild hearing loss on the on the right ear, and the left ear being the worst, had a mild to sloping to moderate hearing loss on the right ear, and the left ear had an asymmetry, being worse, with a similarly moderate severe hearing loss. This is the patient who also presented with a rollover phenomenon that I presented earlier in their speech discrimination score. The second patient presented with asymmetrical, what we would call single-sided deafness. So they had a profound sensorineural hearing loss on the right ear. And so turns out that due to the long waiting time, and the results, the younger patient was sent to do a CT scan just to rule out any intracranial pathology, which ended up being normal, and she's awaiting an MRI. While the elderly patient, upon doing an MRI, was found to have a vestibular schwannoma, small intracanalicular schwannoma, 7 by 7 millimeters. In spite of making the diagnosis due to the comorbidities and the age of the patient, this is a patient that we are doing a watchful waiting kind of approach. Her symptoms have been worsening, though radiological follow-up has shown no interval change in the size of her tumor. So this shows the importance of having a high clinical suspicion, and depending on your audiometrical tests, not just the history of the patient, to decide who can get an MRI and who should get an urgent screening test, especially when you're reviewing these patients in a low resource settings. So you can depend on audiometric tests to decide who is more urgent and who can get an MRI, and who can have time to wait. So in conclusion, the list of differential diagnoses, again, could differ with the age of the patient, the presentation of the patient, and the audiometric results that you get, or the the tests that you get from your audiometric investigations. The diagnostic approach would rely on the three, that is the history, physical exam, and the audiometry, and combining all this makes the sensitivity, or makes it easier for you to decide which patient would be best to send for an MRI. So imaging may not be indicated for all patients, and this is of note, especially in low resource settings. Thank you.
Thanks very much, Lilian. That's a very detailed presentation. One of the difficulties that you pointed out is when MRI is your bottleneck. Now, if you've got an older patient who, even if they have a tumor, which is not a mass occupying lesion opposed to a fossa, and you're not going to offer them treatment, do you think a CT scan is justified as a first-line investigation as opposed to MRI?
Yes, in patients who you suspect to have a large intracranial lesion, CT scan has actually been shown to be an effective screening tool in low resource settings where MRI is not available.
Yeah, but I'm not saying that they might have a large one, but it might not be important to pick up a small one.
Okay.
You're not going to act on it.
Yes.
So the issue really is that if your resources are such that you not be able to offer them stereotactic radiotherapy, or you're not going to operate on a small intracanalicular tumor, would you go for an MRI at all? Would you rather go for CT scan?
I think CT scan would be cheaper and more effective, yes.
More effective.
Yeah, it would make more sense.
Okay. And then you mentioned that calorics is about a 65% sensitivity.
Calorics are about 45.
Yeah, you're 45. Now,
Yes.
do you think with such a low sensitivity, it's a worthwhile test to do?
If you were given a choice between calorics and hyperventilation test, the hyperventilation test is better.
Yes.
It's easier and it's cheaper.
And hyperventilation test only has a sensitivity of 65%.
Yes.
Do you think that's worthwhile doing with such a low sensitivity?
Well, calorics compared to calorics or in general, it is better. It is worthwhile doing. You can do it if you want, especially if the patient has vestibular symptoms. If they get hyperventilation-induced nystagmus, then you suspect a central lesions. Your suspicion is high. So I would recommend that it is done in patients who present with vestibular symptoms, just to rule out a central pathology. Yes.
So you're talking about sensitivity of 65%. The calorics 45%. Is it worthwhile doing those sensitivities?
So yeah, so hyperventilation test is very, not very sensitive. And I think if you're in a well-resourced setting, so the aim of this presentation really was, the MRI is obviously gold standard for asymmetry. And in a developed world setting where people are often afraid of litigation, everybody is scanned. We just don't have that luxury because we've got about 10 to 15 patients who present with asymmetry at every clinic.
Wow.
Now, are you going to scan 200 patients with an MRI a month? That will put your waiting list up to 10 years for the MRI. It's not feasible.
No.
For private patients, even if they're on a medical aid, not everybody has 15 grand before out for an MRI. So in terms of sensitivity, obviously you're going to go for the most sensitive test and whatever is easily available, whatever you can afford. And I think the bottom line is just not to order, I'm going to say indiscriminately in inverted commas. But I find what happens in our clinic is the minute they see asymmetry, then it's an MRI straight away. And what I want people to do is look at it very critically and examine cranial nerves, do a head thrust. If it's coming from the inferior vestibular nerve and you've got a positive head thrust and you've got asymmetry and you've got rollover, well, then you're going to go, well, I should probably do an MRI scan here. If it's an elderly patient, multiple comorbidities, then maybe CT is better, but to look at it critically and not just order MRI like you're in a factory, MRI, because it's not feasible. Yeah. And so you're absolutely right. One would argue, what's the point of doing a hyperventilation test? But maybe if you're in the middle of nowhere and you have no CT and no MRI, and you've got to send that patient off to the next city to have a test, it might be worthwhile. Yeah.
What's your practice in Belgium? They just look at MRIs.
Yeah, every asymmetric hearing loss gets.
Every asymmetric.
It's just medical UK. Yeah. Because they will sue you if you miss it.
Yes.
Yeah.
Yes.
And of course, your MRIs are funded by a national health system.
Yeah.
Well, ours is not yet. And we just don't have that luxury.
Yeah, but the difficulty, as you point out, even if you're on a medical aid in private, you have to pay out of pocket.
Yeah.
And so I can even have a discussion with the patient. Do you want to have it done or don't you?
Yeah.
A CT scan and put the ball back in the patient's court.
Yeah.
And that's protect you from a litigation perspective.
Yeah. Absolutely.
Okay. Is there a question there? No. You want to take over your presentation and see if there are any other questions?
Any questions or comments from the audience?
Good morning.
Morning.
Lufunda. So of all the patients you scan, what proportion of those undergoing MRI and CT do you actually pick up anything at all?
That's a good question. I mean, I'm obviously speaking anecdotally because we haven't looked at that yet. I'm not sure if you can hear me, but I would say probably about 1 or 2 a year. And that's just one.
Yeah, precisely. I practice in Zambia and we have very limited resources. So even to get a CT sometimes is often difficult. So of all the patients I've scanned, I think the past couple of years, it's very unusual I pick up anything at all, unless it's grossly evident. They've got something very big, which is obvious on clinical exam. So now lately I've started actually thinking twice about sending all these patients for this imaging because first of all, it's a very expensive undertaking in my environment, and then very rarely I do pick up anything. So I sometimes I want to like follow up these patients, like the presenter said, probably do some tests maybe after 6 months, after 3 months, and see if anything changes at all. I think that's worked for me so far, but I'm not sure if it's ethical. I don't know what you think.
Yeah, it's very difficult. So, you know, and we don't have a set protocol because I think the problem here with protocols, with a set protocol and following a set protocol is that each individual patient is different, right? And so sometimes if the hearing loss is, if there's slight asymmetry with relatively preserved hearing, we would send for an AVR. And if the AVR is suggestive, then we would scan. If it was a young patient, I would send for an MRI. And for patients who have, where you know, you kind of think, well, I could probably follow this patient up because they don't have any rollover, they don't have any other features of, you know, there's no cranial nerves are all intact, there's no other symptoms. We bring them back for a repeat follow-up. The problem with that is that you then end up with a massive follow-up clinic where you kind of, you know, you look at it and if it's the same and it's unchanged, then what do you do? So I think some of the patients we counsel very, very carefully, and other patients when we feel, you know, I do sometimes, I admittedly do a scan if I want to discharge this patient. So if it's a patient who you're not sure if the headaches are related and there's, you know, there's asymmetry and it's marked asymmetry and you kind of want to go, well, I would like to discharge the patient and I'll follow them up for the next 10 years. I do scan and then say, you know, if the scan's normal, counsel very carefully and then discharge. So we have a very, very mixed approach. But I think the bottom line is that, you know, you have to, I think there's a danger in not scanning anybody. But I think one has to scan, what's the word I'm looking for? Selectively, yeah. And that's the best you can do, really. Because we're not in the States where we can scan everybody.
But you raise the issue about whether it's ethical not to scan people, but you know, this is where the issue comes in with triaging. We triage every day of our lives. You know, we don't do CT scan of every patient with a head and neck cancer, you know, of the chest, do like metastases. We do chest X-rays because if we CT everybody, you know, then people becoming in acute head injuries wouldn't be able to be scanned because we'd be overwhelming our CT scanner. And so if you've got a limited resource setting, it's a question of, do you focus all your resources on the individual patient who's got a very low chance of having a positive result, or do you look at your broader population and say, well, how are your limited scanning facilities used most optimally for your population? And so, so these are the ethical dilemmas that you have to consider.
Certainly, thank you very much. Thanks.
Any
other comments?
Asmita, do you have any comments from Kenya? No. Well, Lilian, thank you very much. That was very detailed, but we obviously need some guidelines. And so we look forward to the guidelines coming to the fore.
Okay, thank you.
Yeah.
Have a nice day,
Thank you,
everyone.
Well done.
Bye.